All right. Good afternoon, ladies and gentlemen who have joined us on this Dr. Fundi channel via multiple social media channels, Facebook, YouTube, Instagram, Twitter. We welcome you to this feature, which we call The Future is Female. As you may know, South Africa has dedicated the month of April as a month of celebrating, women of South Africa, all the way from 1955, those great women who did things. But our focus now is on the women today. What are they doing to deal with the issues of today? And what kind of future are they creating for us today? So we've been running a series of The Future is Female since the beginning of August. And today, our special guest is Dr. Tabane. All right, the full name is Keorapetse Tabane. Now, before we went live, I said I was going to ask her a question. For those people who understand the Sotho language, Keorapetse means I have prayed for you. So it means her mother was a praying woman and is a praying woman. All right, so she was the answer to the prayer. So Dr. Tabane is a pioneering medical oncologist with a strong social conscience that's demonstrated by her philanthropic ventures, where she's doing stuff for young girls through the Happy Me Foundation that she and Dr. Figi Letsela created. So they are co-directors of Happy Me Foundation. And this is a foundation that assists young girls throughout South Africa with access to sanitary kind of, towels and other things like that. But also she does a lot of outreach when it comes to, awareness about various issues relating to cancers, so cancer education and other health topics. So she is a qualified medical oncologist who qualified in May 2008. That's 13 years ago. And at the time, she was the first Black medical oncologist in South Africa. So when I qualified as a medical doctor, many moons ago in 1989, there was no Black medical oncologist up until 13 years ago. And that first person who broke ground is our special guest today. But before then, you don't just become a medical oncologist. You specialize in internal medicine. So she specialized in internal medicine to become a specialist physician. And she became a special physician in 2005. That's about 3 years before she became a medical oncologist. And she did her undergraduate MD-PhD degree at what we used to call Medunsa, the institution that used to be called Medunsa. It's now called Sefako Mahato University. And she qualified in 1999, just when we were finishing the previous century, getting to the new century. All right, so she was ushered into this new century that was actually going to propel her to becoming, a trailblazer. Okay, but she did her internship at Kalafong Hospital. Those who are from Pretoria will know Kalafong Hospital. I would say, is it a district hospital or what kind of a hospital, Doc, it is?
It's a training hospital. It's linked to the University of Pretoria and Steve Biko. Yeah.
Okay, so it's part of the complex.
Yes, correct.
All right, so you did your internship at Kalafong, and you went and did your ComServe in Mukopane. And then after that, you decided back to Joburg, Wits University, I want to be a registrar. You started with some emergency medicine and then you became a registrar. So that's a little bit about Dr. Gia. She did her high school at Toho High School in Macau. That's in Pretoria, if I'm not mistaken. So I've given you basically her educational history so that we can spend more time on the meaty parts of what makes her the great, trailblazing woman that is here today. So she qualified May 2008. 2 months later, she joined the Sentin Oncology, center, which is in Morningside, Johannesburg. And she's a director there, and she's been there ever since. So this is a woman who likes stability. She doesn't like to be in many places. Stick to one place, do your thing, and just excel without having to deal with a lot of change in your life. Right, there she works in a multidisciplinary team of oncologists. And because she works in that multidisciplinary team of oncologists, she works in a multifaceted, treatment approach, where depending on unique issues, unique factors or considerations of each patient, they decide, does this one need surgery first, surgical oncology first, or does this one need radiotherapy first, or does this one need, chemotherapy? So they tailor-make the interventions, and they are able to do that because they work as a team of oncologists. Dr. Keo, Tabane, welcome to Dr. Fundi channel.
Thank you. Thank you for inviting me.
Lovely, lovely. We are going to have fun today. I watched one of your interviews with Leanne sometime last year, and I decided there's 1 or 2 questions I'll steal from that interview, but most of them will be original questions from me. All right, so just tell us a little bit about who is Dr. Keo Tabane. I don't want the professional side, the person.
I agree with you there, because often, we tend to mistake the professional side for who we are, and it isn't. I was saying that to someone last night, actually, that's what I do, what I love to do, what I enjoy, but ultimately that is not who I am. So Keo Tabane is, I'm a mom, a mom to 2. I'm married, I'm a daughter, and a sister, a friend. I was born in, I'm not sure where I was born, whether it was Hebron or Macau, but yeah, there. I don't actually know. I must ask my brothers. But I was born in that region. And because I have 2 brothers, and I think my parents really wanted a daughter. That's how I was named Keorapetse, because they had prayed for a girl, and that was me.
And God delivered.
God delivered, it would appear.
Beautiful. So there's three of you at home, 2 big brothers and yourself. Yes. Meaning, if we hadn't come, they would have continued to try for a woman.
Hey.
For a girl.
Yeah, at some point they would have had to give up, but yeah, maybe they would have carried on trying.
Beautiful, beautiful. So now, being the last born, there's a kind of character or personality that last borns normally have. Firstborns as deputy parents, lastborns, and the middle children. So you being the lastborn, do you have any lastborn tendencies?
I don't think so, because I think that me being the only girl also positions me differently, because, brothers also sometimes need to be reined in, so we can move forward in terms of decisions, family discussions, and so forth. And I find that as the girl, especially as we grow older, I probably become like the older sister in a sense. And I hope they're not listening.
Yeah, well, I mean, but it's known that, women tend to mature much faster than us. And so it's not a surprise to me that being the last one, you actually are deferred for, firstborn when it comes to, family. All right, no, but so you grew up in Macau?
No, I grew up in Hebron.
In Hebron, okay.
Yeah, and then went to school
on the other side of Pretoria.
Yes, correct. Close to Harankua and Mabopani, that area.
All right, so what language do you speak then?
I'm a Motswana.
Yes, no, you see, Pretoria people, you can't exactly say Motswana, Mupedi, and all of that. There's that unique language of Pretoria, Sipitori. So, yeah, that's why I'm asking you the question.
Mm. Yeah, no, I'm a Motswana. So my mom was actually a head of department at the local College of Education of Setswana. So we didn't have a chance to speak this sort of Pitori language. We spoke Setswana. And my mom was very sensitive about those sort of, you know, she needed us to speak proper Setswana. So that,
Setswana.
Yes,
so Botswana, there's Bakhatla, there's different Bakwena and Burolongs, and so which one of the Botswana?
So Papa ke Mokhatla and Mama Nele Mokwena. So then Khorari ke Mokhatla then.
Okay, lovely. Okay, right. So let's get on with the business then. So Doc, I introduced you as a medical oncologist. For the uninitiated, what is a medical oncologist and how do they differ from other types of oncologists?
So a medical oncologist is firstly a specialist physician, which means that from the undergrad, there is an interval a specialty of internal medicine. And only from there does one then subspecialize in medical oncology. And so what medical oncology is, one is that you're a physician. Two is that you treat cancer using therapies, systemic therapies like chemotherapy, hormonal blockade, immunotherapy, etc. But we don't treat with radiation. And so the benefit of working in a multidisciplinary panel and also in a center like Sentinel Oncology is that within the same complex, you've got us, the medical oncologists, and then you've got the radiation oncologists who are experts in the delivery of radiation treatments. And therefore, we are able to work together to optimize patient care in that way.
Yes. Okay. All right. But is there a situation where one is able to deliver both? I'm thinking now about, provinces like the one I come from, which is the Eastern Cape, which struggles to, attract people of your caliber. So is there someone who's able to deal with radiation side and also the medical, oncology side?
Yes. So the landscape in South Africa is that mainly medical oncologists are actually mainly in Gauteng. Because Wits and Pretoria have got a medical oncology training. But if you look at the coast and in other parts of the country, it's either radiation oncologists who then would give chemotherapy because there aren't enough medical oncologists, or clinical oncologists who are not physicians, but they migrate directly from their undergrad into clinical oncology training, which encompasses both chemotherapy, systemic therapies, and radiation. So mainly if you look at the coastal areas, PE, Cape Town, George, the doctors, they are either radiation oncologists who also do chemotherapy or trained clinical oncologists. Yeah.
All right, beautiful. Because I was worried about the fact that, if you were the first one 13 years ago, and there tends to be distribution of skilled people like you, in places like Joburg, Pretoria, Cape Town, Durban, then, if we need to have the individual oncologist, then it might be a bit of a challenge. Okay, now I'm happy about that. All right. So I'm told at the age of 4, you decided to tag along when your mom was, as a school principal. You tagged along. The plan was not for you to start schooling. You were supposed to be there just to spend time, but you ended up, starting school with much older people. Tell us a little bit about that.
So, funny enough, I don't have a lot of clear memories about my childhood, but I do remember this morning quite distinctly. So what had happened was that my mom had arranged a helper to a childminder to come and stay with me. It was a Monday morning, right? So this woman childminder arrives in the morning, and I remember I looked at her and I said, I'm not staying home. And now it's Monday morning. My mom is a principal at the local school. Everyone is getting ready to leave. Your 4-year-old then says, no, I'm not staying. I'm not staying with her, unfortunately. So, so then my mom obviously then had to decide what to do. So in a quick thinking way, I said, okay, fine, come with me. I'll, put you in the office while I figure out what to do with you, since you don't want to stay with this particular lady.
Yeah.
So that's how I ended up going with her to school, and I was in her office, and of course, when she wanted to have meetings, then she asked one of the teachers to say, okay, I've got a meeting. Please, can she be in your class for a little while? I just still need to figure out, who I can get to stay with her and so forth. That's how I ended up in class. So it was really just my mom trying to manage work and motherhood, which clearly this is an old conversation that even in our mom's days, people are trying to juggle, parenting and work and so forth. So then I was in a class, and I think apparently after a few days, the teacher came to my mom and said, she seems to be doing quite well, actually. Maybe she should just stay. And I presume my mom, that was the path of least resistance. I'm sure for her, she said, wonderful. Then she didn't have to worry more about finding someone to stay with me at home. So that's how my schooling journey started. It was by accident and maybe a little bit of stubbornness, on the part of a 4-year-old.
Wow. Okay. All right. And so what that means is that most probably for the whole 12 years of your schooling, you must have been the youngest in the class, which comes with its own challenges. So just, how did that affect you, positively or negatively?
Yeah, absolutely. And, I mean, I've got a 4-year-old about to turn 5 at the moment. And I look at her and think, shoo, I was young. I was too young to start school, honestly. And I think that obviously over the years, we've learned also about emotional intelligence and readiness and that, and not just about intellectual ability. So yes, it could have been that intellectually I was competent, but I wasn't ready. And
you're not well rounded at the time.
Yes, and so you carry that not readiness with you throughout. And the positive and the negative. The positive is that then you're always pushing, punching above your weight, and that is the positive part of it. The negative is that it gets tiring to always punch and push and perform and deliver consistently. It gets tiring.
Wow. Okay. Well, I also started at 4, so I can relate. I can relate. Intellectually, yes, but on the other aspects, emotional and socially, I don't think I was, well-rounded at all. And so I can understand that. So, what did you want to be when you grow up at that point? Schooling, and I'm not talking secondary, in junior.
I don't remember what I wanted to be. I do remember that when I got to high school, I then thought I wanted to be a doctor, but there was a teacher who did, what was that lesson where they guide us about what to do? Career guidance.
Career guidance, yeah.
Yeah, who told me there were too many doctors, so then discouraged me. So then I abandoned that and thought I wanted to be a physiotherapist. Yeah. And then so then my mom, in retrospect, I see what she was doing, because she never disagreed. She just said, arranged for me to spend a day with a physiotherapist. At the end of my matric, I spent the morning with a physiotherapist, and then when I got home, then I realized that that's not really what I wanted to do, and that even just with my physique, I just was not going to manage. So I see what my mom did there. She never pressured me to be a doctor at all. She just,
in case you rebel.
Yes, and said, yeah, but here's your degree, kind of thing, So then I decided that, actually, even though there are apparently too many doctors, I'm going to do medicine. And I realized how excited she was when I said that. And the penny dropped, that in fact, that's what she'd always wanted. But I only realized it after I thought I had come to that decision, when in fact, I think she had a hand.
Worked behind the scenes, pulled the strings gently, and you were not even aware that, there's a puppet master behind you.
Yeah, so then I did medicine. So when I was doing medicine, I thought I wanted to be a cardiothoracic surgeon.
Wait, Doc, wait, we're gonna get there. We'll get there, yeah? And so the other thing I want to know, in the schooling years, how would you describe yourself as a child? I was a naughty boy, and all of that. So were you the bookie type, too much into books, staying in the house, hardly go and play with other kids out there. If you're not at home, you are dropped at the library kind of thing. So what kind of child were you?
So I was maybe boring a bit, and also my parents were very strict. So there was no opportunity to venture into anything. My dad was a priest and a librarian. So priest and librarian. So you can imagine, right? and my mom was a lecturer, head of department in a college and whatnot. So there was that space. So I was either at church. I mean, we used to be in church all the time, except Thursdays. That's how Thursdays became my favorite day of the week, because Thursdays I didn't have to go anywhere.
Sheila's Day. It's called Sheila's Day. That's the day
yes.
Help us get to be given time to socialize.
Yeah. So or I was at school or at the library. Like sometimes, I would go to my dad's workplace after work, wait for him there in the library. So I lived quite a protected life, and I had times where I wished, I saw friends going, before they would like hire a combi to go to places, to have fun, and I would see them pass, and I would be so, down.
Yeah.
And I couldn't understand why my parents were holding me prisoner. But now, looking back, I understand.
You understand? No, they had a plan. Okay, so you knew that you wanted to be a doctor after that, shadowing of a physiotherapist, and then you applied to a number of universities, I'm assuming, right? And then you chose SMU.
Remember, I wanted to be a physio, so I'd applied to a number of universities for physio.
Oh.
And yeah, it was very late in the day when my mom intervened. So I had applied and I'd been accepted to UCT for physio. So that was done. I was going to UCT too. So at the last minute, literally in January, when I was supposed to now leave, that's when my mom arranged this shadowing. And and the shadowing was at Medunsa with this physiotherapist. So when I then decided that, actually, I don't really think I want to be a physio, I then applied to Medunsa at the last, literally the last minute. And and by the grace of God, I was accepted.
And with mom being, somebody influential who knows people, I'm sure there were some few phone calls that had to be made there, to allow you, with your late, application, because your results must have been, quite good.
My results were fair. I must be honest. My results were okay. They were not amazing, to be honest. I mean, I had a C in matric.
Yeah.
So it wasn't. No, I had a B. Yeah. Yes. Remember at that time when it shows my age, back in the day, that's how they.
Yeah, we used to talk about the A's and the
A, B, and yes.
And the 6s and the 5s that they talk about today.
Yes. Yeah. So I had a B. So it was okay. It was not, fireworks. But then, I got in.
No, but we understand. I mean, you were 16 or something when you did your matric, Yes. So you were not fully developed. Okay. So you then, started medicine at SMU. Must have been age 17.
Yes, I turned, so it was 94. 94.
Yeah, I was age 17. Wow. All right, so quickly, so you then went in to do your medicine from first year. At least it was not far away like UCT. You were in Pretoria, relatively familiar surroundings in Garangua. You could phone mom and she could come, or you could phone dad and they could come, or weekends you could go home. So how did you find the transition from high school to university?
I loved it. Loved it. Because now I could do my own thing, because even though I was very close to home, literally my home from the varsity was one taxi ride of about 20 minutes, right? Yeah. I stayed on campus and I loved it. I had fun. I had a wonderful time.
Beautiful, beautiful, beautiful. All right, so that's where you developed, you started to know a little bit more than when you were sheltered at home. You started to socialize. I'm sure a number of friends that you still keep today, you must have met there.
Yes, it's true. Correct. And it's nice to be able to reflect with those friends from you know, from the mid 90s, you know, 94, 5, and reflect back on our days at university. And those are special friends, you know, people who have known you before any titles came, and just you, and yeah, so that's really quite a blessing to have those kind of friends still.
All right, as part of growing up, being a young girl from a protected environment, Papa Kimurudi, my mother is an educationist of note. Now you have a bit of freedom. The other gender, you start, you know, getting people, you know, coming to say sweet nothings to you. How was that harassment adversity?
That was great. You know, I enjoyed university, and you know, and I look back at that time and I think, sure, when I did not realize at that time that that was among the best times in my life. I think when I hear young people wanting to rush through youth, rush to the end, rush to work, I think you don't know that this time is really just such a, because you're in the middle, you have your freedom, but you can go home, you know, so you're not really, you can, it's almost like having the best of both worlds, you know, you can be a child when you choose to, you can be so that I just really had a good time. Yeah.
All right, so as you were doing your undergrad MPCHP, which discipline, you know, when you look now over the 6 years, was actually close to your heart, and you thought, this one, I'm going to proceed and become a specialist in this one?
So I thought I wanted to be a cardiothoracic surgeon.
Why?
Until I realized that it took me longer to stitch a CVP line than to put it in, just to secure it in place. It took me longer. Then I realized that no, I'm not dexterous, and this is not going to work. And in fact, I remember when I was doing my internship, you know, in the surgical rotation, there was a roster, the roster for theater days and the roster for post-op care. So then, you know, you would meet patients post-op. I remember on my theater days, I would be in tears, wanting to swap with somebody. I wanted to meet the patients in the ward post-op. Then I could take care of them, sort out their HPs, you know, sort out all those things. Then I realized that actually being a physician is what I was attuned to, but not the cutting, the scrubs, the theater lights. No.
Yeah, so you were not cut out to cut out people.
No, not at all. I'm a communicator. I talked. I enjoyed talking to patients, and that's when I'm at my best.
And also going through your battery of tests of all possibilities, to work things down from 20 possibilities to to the next.
Yes.
Okay. Diagnosis. All right. Okay, doc. So you then saw that cardiothoracic was not for you. That is a super specialty role of general surgery, right?
Yes.
So
I was dreaming.
You are not going to be the person, you know, who cuts people and remove or do removal of lungs and whatever. That's not you. Okay, that's fine. So then, what was your second choice?
So initially, I thought I wanted to be a physician, but I hadn't thought that after the physician bit, I would want to do anything else, right?
Yeah.
So I thought I wanted to be a physician. So it's only when I got there that I realized that it wasn't going to work either. In that it's good to be a physician, but I wasn't going to be able to sustain it. It's a lot of work.
How, doc? Honestly, it gives you variety.
No, there's a point where there is so much information in the medical space as it stands now with oncology. It's difficult to keep up, but you keep trying and you're trying it. So imagine if I had to keep up with everything, I wouldn't manage.
Yeah. Okay. All right.
Yeah.
Okay.
And also, apart from that, from a lifestyle perspective, oncology works for me.
Okay. As a mom, as a wife, it gives a bit of balance. Yet with internal medicine and everything, you could be called anytime. You can't exactly plan things, according to yourself. All right. And so you decided after you spent time in Mukopane that is post-fitness rest, that you're coming back to Joburg and you're going to do internal medicine. And indeed, from 2001, you started doing internal medicine, you know, and 2005, you were done with internal medicine. But by that time, you made up your mind already, by the time you got your FCP, that I am going further.
Yes, but I didn't know what I was going to do. So what happened was that at first I didn't like oncology.
Yeah.
So I wasn't going to do oncology. What happened was that, so in the rotations, you've got a time to say your time is going to end. Your 4 years ends here, right? So my 4 years was ending in June 2006. But in November 2005, I did my exam. So I had to kill this remaining 7 months before I could move on to the next thing, right?
Yeah.
So in that 7 months, there was an oncologist, Professor Dimitru, who used to say to me, you know, why don't you come and try this oncology? You know, we think you'll be good at it. And you know, she tried to, every opportunity she got, she tried to convince me that this oncology was something I could do. So I went because, you know what, I have 7 months to kill, you know, what would it hurt? So I went, and then I enjoyed it. And then I thought I could do this, you know, and I just felt that I had a natural grasp of the issues. I didn't feel it was a struggle to understand the issues, the principles. Because once you understand the principles, everything is easy because you can make sense of everything. So the actual grainy information you can always attach, but if the principles are solid, then it's easy going, right? So I just felt that I had a natural grasp of the issues, and then I stayed, and that's me. That's how I got into oncology. But to be honest, when I was doing internal medicine and I first rotated as a junior registrar in oncology, I didn't like it at all. In fact, I dreaded it a little bit. But when I went back as a senior registrar who had completed their time, and maybe I was more mature in that, I loved it.
Okay, all right. And so that meant an extra 3 years of training, you know, for you to actually then be a medical oncologist, which you eventually became in May of 2008. Right. So that what is the highlight for you for that 3 years? You remember now, you are the first Black woman who's being trained to become a medical oncologist. Or there were many of you, but you were the first to pass, I'm not sure. But you know, the fact that there weren't people like you who were medical oncologists at that time, did that not put pressure on you? No, I didn't
feel that way. I didn't, in a sense, I didn't internalize it. Yeah, no, I must be honest, I didn't internalize it. It actually dawned on me close to the exams and after passing, but it was not something that I was consciously aware. It was not in my consciousness that, yo, you know, I'm the only Black person, whoa, you know. No, I was there and it was working out. And I realized only after or around the exams that, wow, actually they aren't, you know. So it's never really been a thing in the center of my consciousness when I was training to be a medical oncologist at all.
All right. Okay. Now, I just want to then understand, when you then got, you know, your results that you've passed and you are now a medical oncologist, what did it mean to you? What did it mean to your parents? And what did it mean to the broader extended family?
Yeah, so it was very exciting. You know, that I was there, but I guess, you see, often people think, because I didn't set out wanting to be a medical oncologist, so it didn't feel like I'd arrived anyway.
Yes.
It was part of the evolution of my journey, and I was there and I was looking forward to seeing what it would, how it would pan out. It wasn't a destination, so it was just another page, another chapter. I was grateful, excited, and carried on.
I'm going to ask you then a question. Living in South Africa with legacies of apartheid, issues of race, and also issues of patriarchy, as you were going up this journey, and then your first few years as a medical oncologist, did you experience any challenges or difficulties specifically from those areas?
Absolutely. So what happened was that, so I finished, my time finished of the sort of rotation on the 30th of June, 2008. On the 2nd of July, I was in private practice under a Dr. Daniel Vorobiev, who has since retired, the founder of Center Oncology. Yeah. So he had sort of approached me, and I thought, oh, well, why not? And so I went to join him, and he was like a mentor to me, and just just polished up and got me going. And I must say, so by that time, nobody knew who Tabane was, right? And I looked, I mean, as it stands now, I look younger than I am. So you can imagine 13 years ago, I looked a whole lot younger.
Yeah, but I saw some of your pictures.
And this is oncology, it's a serious discipline. I mean, all disciplines are serious, but here people think they're dying. So this young person, so often, actually in my mind, it was almost like a game, but sometimes it was hurtful. Like patients would make an appointment. Some would call to cancel after they have asked around, or they would phone to ask, like, is this person, are they Black? They would phone the rooms to find out if I'm Black, and if I'm, then they would cancel, right? So I would see 2 patients a day. I'll read the newspaper until I knew all the news. There's nothing to do, right? And when you have 3 patients booked and 1 cancels, it's hurtful because you're not yet mature to realize it's not about you. You're not, your confidence hasn't come to say, oh, well, you're lost. You're not there yet. You are still, insecure and uncertain. And sometimes when I open the door, so I would have a new patient, right? And I would open the door to call them in. And that 2 seconds of horror when they saw me was like, whew, they would just freeze, like, oh my goodness, is this the person who have come to see, So in fact, I used to almost sometimes enjoy it, open the door and look at them and so it was tough, because you're not yet ready. You don't know that it's not about you. People are just afraid, and they've got their own predetermined ideas. It's actually not about.
Remember also the diagnosis itself. It's a diagnosis that makes people very emotional. People think the diagnosis and they think death. So then they come and meet this young woman with a lot of melanin.
Yeah, I mean, I remember one case distinctly where the patient said, he was an older man in his 70s, had just been diagnosed with cancer, and he comes into my office and he says to me, after discussing, he said, I need to make an appointment to see Dr. Vorobiev. This is not a Mickey Mouse situation. He says this to me, that this is not a Mickey Mouse situation.
Yeah.
So what does it, so it means that if you're seeing me, it's a Mickey Mouse thing. This is serious. I need to see the senior doctor. And there were many events, many incidents of that nature. And eventually you grow and you become established, and you get confidence, and then it stops to matter. If people feel that they want to cancel because I'm Black, then it's fine, because then I realize I don't want to be their doctor anyway. So it's fine, right? Yeah.
I'll ask you another one. So, in situations like this, even ourselves, sometimes we don't trust our own. And I would rather get somebody with lower levels of melanin than I have, because I have ingrained within me that they are better off. We write the same exams, but they are better off than the counterpart who's got a lot of melanin. So any situation like that where you were sort of rejected by your own.
Yes, and I remember it so well. So what happened was that in order to keep me busy, because I didn't have work, I would have 1 or 2 patients, Dr. Vorobiev, because he was mentoring me, he then asked me to see his follow-up. So those who had cancer 15 years ago, who have got no problem, who just come once a year to hear that they're still well, I would see those, which I didn't mind, because I could learn I could look through the file and see what he did, how he managed the patients, so I could use that as a learning experience. So there was the one day that there was this patient that was booked to see me. She was a Black, accomplished woman. And I don't know what had happened with the booking, and whether it was not clarified that she would be seeing me. she was furious. She was furious that she felt that the doctor was racist. And I had assumed that Black people want to be seen by Black people. And she didn't want to see me. It was quite a scene actually at the practice, her shouting obscenities and so forth. Because
and this is a woman to another woman.
A Black woman, yeah. And the interesting thing is that she then agreed she was going to see me anyway. And then the consult went on, and I suppose somewhere in the consult, she might have noticed that I actually seemed to know something, right?
Now you brought your A game, Pela. You were being challenged.
I brought my A game. So then she starts to come down and say, she's apologetic. No, I can see that, you must be good. That's why you are in this practice. And then I just basically said, with due respect, I do not need that kind of validation from you.
Yeah.
And I kept quiet, and there was a silence where we can both digest this truth. And since then, she has been amazing. We have had a fantastic relationship. At that moment, when I said to her, I do not need this validation. Thank you, but I'm okay without you now affirming me in this moment. And I could see in that time the relationship switch. And even today, she still comes to see me once a year. And we have moved on. So it also just speaks to boundaries of respect, and to say, as doctors, we can define the rules of engagement.
Yeah. All right. So, Doc, now I just want us to look broadly now. We've looked at your journey to becoming a medical oncologist. Now I want us to look at the challenge of cancers, in the country. All right. We know that South Africa, year on year, the burden of disease from non-communicable diseases or non-infectious diseases is increasing. And amongst those are cancers, right? What trends have you seen? What trends are you noticing around the issue of cancer, in South Africa?
Yeah, so the difficulty in South Africa is that a lot of what we say are anecdotes, because unfortunately our registry is not up to date.
Yeah, I was going to ask you about that cancer registry and the challenges. Maybe you can just talk about it. Let's even start about that, because we don't have good stats, good data as a result of the registry that is not up to scratch.
But the sense, though, is that there seems to be increasing, cancer diagnosis, in the public sector, in the private sector, whether that is lifestyle or stress or the environment. There does seem to be an increase. And interestingly, in the COVID era, what we are actually now seeing is an increase in late diagnosis also. So someone will say, I felt a lump before the lockdown, but then I didn't want to go to the hospital. And, so that's actually beyond the many cancers. Now we are seeing advanced disease, which is going to be the next consequence, in fact, of this pandemic.
And I'm sure then that creates a problem, because, again, the legacy of apartheid is still there. The majority of Black patients, levels of awareness are low. Screening is not something that they normally do for early diagnosis, and access to proper diagnosis and staging, especially in the outlying areas. I'm sure there's a challenge there. And actually having access now to somebody like you to provide the treatment, So if the pandemic has created the situation of late presentation, but then it will be worse in that sector of the population.
Absolutely, because also, I actually am starting to think that there is some sort of awareness about cancer, but the practicality of it on the background of the apartheid legacies and the health system and so forth is that the public sector is not able to absorb screening. Screening basically means a well person who's got no medical problems goes to a facility to have a screening test. You know, as it stands, the facilities can absorb and manage enough sick people. So let alone screening. So already the screening, you know, falls by the wayside simply because the facilities aren't geared to absorb well people.
Yes.
Right?
Now, I'm just going to mention something related to what you just mentioned, Doc. In my own company, which is employee wellness company, we've just done some work, or we are doing some work with AstraZeneca, you know, as part of their Pagamisa, you know, outreach program, where they are trying to increase awareness, early screening, early access to treatment for the two top cancers, which is breast cancer for females and prostate cancer for males. But the challenge there now is, if we are effective in unearthing people that, you know, are suspicious or actually have the problem of whether breast cancer or prostate, it's going to be a flood of patients that would then need proper diagnosis, staging, and stuff. And so the question is, if we manage to increase the numbers of people who need to be diagnosed and staged, will the system be able to actually, you know, provide the adequate type of interventions? You know, it is a question that I have, but at the same time, everybody needs a chance. Elsewhere in the world, you know, cancers are diagnosed much early, such that, you know, most people survive. But in our country, cancers are diagnosed late in general.
But, you know, Doc, in fact, what you are saying is that, you know, as you know, South Africa is a very uneven society, because even in South Africa, the cancers that we see in private are so early. Sometimes it's like a stage naught.
Yeah.
Right? This was seen on screening, and then they saw some calcifications, and right?
Yeah.
And then 10 kilos away, it's a big tumors, advanced disease in one city, which is, you know, sometimes can seem a bit discouraging, you know, because just also your experience with Pagamisa, we had also experience with the pillow paper train. So Roche used to have that pillow paper train.
Yeah.
And I used to assist with training and not. The thing is, when you now find this diagnosis, now you must take a biopsy, right? Now, when you've taken this biopsy, you must also find the patient, right? They came to this train, they've gone, they don't have an address. You've done a biopsy or a pap smear to find the patient. For them now to go 100 kilometers, it can feel a bit discouraging, but I do think we still have to keep at it. We have to still keep at it within our abilities to help, because if you all get discouraged, then nothing's going to happen. But you know, in our little places, we can try and do something. Okay.
So, Doc, you now have been a medical oncologist for 13 years. I'm sure you're qualified to give me an answer on this one. What makes a good medical oncologist? I'm not talking about the knowledge part, but I'm talking about the personality, like you said the other time, that surgery was not for you. What makes you to be at home with the work of being an oncologist? Remember, here people come in, they're already thinking death. All right. And in that kind of situation, there's even what we call anticipatory grief, because people are anticipating at a certain endpoint, which may not necessarily be. And so I don't think it's only about the medicines that you give, but there's a lot of some, as a family physician, we talk about biopsychosocial, spiritual, a much more holistic approach to dealing with your patient. So what would be, in your view, the top 3 qualities that makes one to be at home in being a medical oncologist?
I would say, I think the biggest thing, I think it's communication. I think you can have the best knowledge and know the latest journals. If you cannot communicate clearly with compassion and wisdom and patience, then whatever you know will not amount to anything. Because in fact, I would even go further and say the drugs and the wonderful drugs that we give and all that, I think actually a small portion of what we do, to be honest. I think the biggest thing is the communication. And which I find, in fact, I was saying to someone this week, I almost feel like the biggest shortcoming of our training is the fact that nobody talks to us about communication when we are training. Nobody. It's like communication is a side issue. Then you have to figure it out when you get into the real world that actually communication is so important. And the fact that there is no discussion about communication in our training is a huge shortcoming in my view. That's the one thing. The other thing is I think a good doctor is a doctor who knows when they're at the crossroads.
Yeah.
When you can realize when you are not sure what's happening, then I think you're a good doctor, because then you have an opportunity to stop, ask colleagues, read around it, discuss with the patient, and make the right decision. So you've got to realize when you don't know what to do, when you are at the crossroads. If you can identify,
you must know what you don't know.
Yes, and then you can go and find it out. So I think that's the next thing. And also listening. You know, someone said, and I don't know who said this, but said that patients always tell you what's wrong with them. You just ought to listen. They tell you what is wrong. They may not tell it in medical terms, but if you listen long enough, you will actually understand what the issue is for a particular patient. So I would think communication, knowing what you don't know and being able to stop and seek the necessary advice, and listening.
Right. Now, I'm almost getting a sense that you were this sort of like, as much as you appear as someone who talks a lot, in fact, that's what you say, but your natural default, more like introverted. Would I be right? Or there's also something called extrovert, introvert, or introvert, extrovert. How would you describe yourself? Because people like me who are like pure extroverts, they tend to be poor in listening. We always want to say something even before the other person has actually communicated.
Yes, we listen to respond.
Yes.
Listen to respond. So I think, I don't know, I don't think I fall in one or the other group, because I talk a lot, but I'm not a socialite. So I'll talk a lot in my work environment. I talk in that space a lot, and I talk with people in my immediate circle. But otherwise, I'm not very good as a extrovert, talking to people, making friends. I mean, I can literally count my friends on one hand. I don't have groups of friends that I belong to. I can't sort of do group friendships.
That means less headaches for you.
Hey, no, if you have few friends, there are relationships to maintain, So few friends. It's one-on-one, it's not a group.
All right. So, but growing up being a pastor or a priest's child, don't you think it brings some advantage, especially on the spiritual side, more especially maybe for those who are Christian? The fact that you grew up in a religious environment, the only day you didn't go to church was a Thursday. So there's a couple of scriptures that you can always, prescribe over, and once you've done your core work, not as a substitute to your core work.
No, so it makes a huge difference for me spiritually to also cope with the kind of environment that I'm in every day.
Yeah.
So it helps me to be able to cope and to have compassion, because I don't think compassion is a natural response every day.
Yeah.
You get compassion fatigue.
Yes.
And it's not a natural thing every day that you're compassionate. So when spiritually, and when I prepare my mind in the morning, and that just helps for me to harness those aspects of my being.
Yes.
That aren't always natural.
Yeah. Okay, so Doc, I've invited somebody here, somebody special, somebody who appreciates your professional work. Somebody who said, Fundile, in your profiling of people during the month of August, this is the name I am recommending that, you must make sure that, she gets, to be profiled. And then I surprised her just before we went live by saying, I want her in. She must come in. This person is a family friend to me, Mrs. Miranda Makwetu. She is the wife of the late Tibi Makwetu, who passed, late last year from CA lung, the complications of CA lung. So I'm going to ask her to just tell us a little bit about her experience. She's obviously, for her to recommend that, you are such a good medical oncologist is because of the experience that she got with you. So for me, that's good, because for somebody who has lost a loved one, but still says big ups, to Tabane, there's something good that you are doing, Doc. And I feel, it's important that sometimes we don't tell people about the good that they do. But when we have a bad experience, we are able to go out there, shout and make noise about how bad that person is. So I'm going to ask Sis Miranda. Sis Miranda, unmute sis.
I'm here.
All right.
Oh, okay. Oh, okay. You can see me now.
Just your forehead.
Okay.
Right. No, right. Thank you very much, Ms. Miranda, for just agreeing, man, to join us on this, session of celebrating with Dr. Keo. I felt for her during the funeral, where she had to come and be one of the speakers. She had to be one of the speakers, and I thought, sure, I wouldn't wish to be in her shoes today. Because just, everybody, the mood is somber, everyone is crying, and you have to go there and actually be able to say, we tried 1, 2, 3, 4, 5, but unfortunately, God had other plans. So, Sis Miranda, your experience of working with Dr. Kim.
Okay. When I spoke to you and I asked you if you could profile her, I then asked her, because she's a very private person, I asked her, Dr. T, that's what you called her, Nogimi from Tabane. Everybody called Dr. Kia, but you called her Dr. T. I said, Dr. T, would you mind if Fundile does this for her, for his Dr. Fundi platform? And she said, no, go ahead. And I still said to her, I know you don't need
validation.
To be made, you don't need to be made famous or anything. You know what you're doing. But for me, it's just that I would love more people to know that there are people like you out there. And I'm grateful that she agreed, and I'm grateful that you went ahead with the interview. It's a bit of a trigger for me, because when I see her, I remember that I used to sit in her rooms with Kimi. And I wasn't going to internalize it, but I think it's coming, but bear with me. So when you say, when she talks about the first impression, that's exactly what happened with Kimi and me when we went to see her. So we're sitting, Kimi is apprehensive, I'm sitting next to him outside the room, and then there's another patient inside, and then this person leaves, and then she opens the door and she said, Dr. Makwetu, please come through. So Kimi and I with each other. She has a small frame, so she looked like a 24-year-old young girl. So Kimi looked at me, and I looked at him, and then we didn't say anything. But me, Mos, I got a big mouth. So I went in and I introduced myself as the caregiver. And then I said, sure, when we saw you, I wasn't sure if you are the doctor, but then you came out of the room, and then she laughed and she said, no, I always get this this feedback from people. And then we sat down, and then I feel sorry for her, because the relationship was between her and Kim. But
Yeah.
being me, I plummeted with questions. She was very patient. I asked her a million questions. I even said to her, I don't agree with the diagnosis that Kimi is stage 4, because in my understanding, the cancer is...
You're challenging the medical oncologist.
Dr. Makwethu from the Google Institute. I said, doctor, no, I can't be stage 4, because part of me was hopeful and part of me was in denial. I said, no, you can't tell me that it's stage 4, because the cancer hasn't moved. Now you've got your own terminology, but whatever that term
Metastasis,
is.
yeah.
Yes. My tongue always catches on that. So I said to her, but it hasn't moved, so it's in one place. And then she looked at me and said, Mama Makwethu, it's stage 4 because it's moved into the pleural space, the pleural effusion. So I'm sorry, but it's stage 4. So I sat there and I looked at her and I thought, okay, now it's not the young girl image. This is now the real doctor. But the way she said that with such compassion and professionalism. And then she gave us hope when we left that room, beside gossiping about her small frame and her high heels. She had these high heels, and then she walks around like, I know what I'm doing, so don't mess with me. And she had a pink stethoscope that day. So we came home, and I think to distract ourselves, we spoke about that. But beyond that, she told us that it's a very rough cancer, and she promised she would do everything in her power to help Ukimi and to make sure that she can lengthen her and his life. And for that, I'll forever be grateful, because I feel we got 2.5 years out of the therapy. So that was my first impression. But then also in the subsequent meetings with her, she was very patient with me, because I then asked her questions. I would read up and I would say, doctor, there's this now, have you know? And she was always a step ahead. She says, yes, Mama Kwetu, I know about that. And then she would fly around the world to all these meetings to be up to scratch with what was happening. So when I say I trusted her fully, I mean I gave her 100% and another 100. So we felt we're in good hands. Her wisdom, she said, you need to be compassionate. We experienced that. The communication, she did communicate. She even went beyond. She would check up on Ukimi, and her staff would also check up on him. And when she spent time with you, it took me time to realize that there was time for a session. I thought you just go in there and just go on. So sometimes I would tease her, sometimes we would talk about serious things, and then we'd get to the real thing, the therapy. And she never said once, okay, look, your time is up. So it took me a couple of sessions to realize that actually we had a booking and there are people waiting outside. So when you spend time with her, she treats you like you are the only patient she has for the day. And that to me was very important. So you're right, she spoke at Kimi's funeral, and I know it was a difficult thing for her, but I asked her because, Kimi didn't tell anybody about the cancer. It was his wish. And then, so people kept thinking that out of all the things that I could have chosen to say Kimi passed on from, I chose cancer. So now when you have a doctor coming through and saying, yes, Kimi came to me in June 2018 and I first saw him that day, then it allayed a lot of people's suspicions, and they felt, yeah. There's a lot of theory, because as his frame went smaller and smaller, he had full-blown AIDS, he was HIV positive, he was diabetic, he was poisoned, some by me, some at work. So there are a lot of theories. So when she came out and said, I said to her, I know you are very busy, but would you mind talking? And she said she would. And what she said there, for me, if she had just got up and said, yes, I was Kimi's doctor, and that's it, that was enough for me. But then she went beyond. She she comforted me with her words. And actually, I didn't cry through the whole funeral. I only cried when I saw her because it reminded me that it's the first time she's seeing me without Kimi next to me. Even though he was there, but now he was lying flat. But so our journey, Dr. T, is not something I would wish on someone. It's not nice to have cancer, but if possible, I would wish everybody a Dr. T in their life if they happen to have cancer. And I'm extremely grateful. My family, the kids know who Dr. T is. And as you know, as the person who has agreed to write the foreword for my book, when you now read about Dr. T, because the whole book is about Dr. T and Kimi, you would then understand that you're talking about Dr. T that you have met. And I must say, I really enjoyed this interview. For me, I saw a different side of Dr. Tabane because she's always professional and a doctor. Yeah. And I'm looking at her now, she's laughing, she's making jokes. I'm like, oh, okay, she is human. There's something there's life beyond Dr. T. So I really am grateful that we were able to have this interview and to introduce her to the world. It's not something I would wish on anyone to have cancer, but it's also my wish that if they could have cancer, they would have someone, if not Dr. T, then someone like Dr. T in their lives. She made the journey bearable. And even till the very last minute, she never gave up hope. And I think part of that, maybe I was blind or maybe I was too hopeful. I really didn't think that it was the last day. Even when it happened, I was like, what happened? Because I kept on hoping, but she did say from the word go that she would do everything possible. And yeah, so we are truly grateful to her, and excuse me crying and all that.
Yes.
But so thank you, Dr. T, for coming through, and thank you, Dr. Fundi, for this wonderful interview.
Yeah, I think for me, it's very important. By the way, it's good for you to cry. We've got this thing where when we see tears, we then want the person to stop crying. The grief process, you help it by allowing the person to express their emotions, and not, no. It's important that a person goes through the emotions. It's part of the healing process. And so I'm happy that you are actually crying, because those are tears of joy, the good moments in that room with Dr. Keo, and the ups and downs, the times Manum Vurvaya, because Dr. Google can make people to think sometimes they know things that they don't know, but at the end of the day, it was about the love and the care you had for your partner. And that's very important. And today is the 14th of August. The 1st of August is World Lung Cancer Day. So that's about 14 days ago. And, Ukimi passed on as a result of complication of lung cancer. So actually this month, especially that day, the 1st of August, is about, increasing awareness and encouraging, people, to be aware of symptoms and early diagnosis and all of those things. So it's actually appropriate that you've got Dr. Keo here, and also we're talking about somebody that we really, 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 connected with, which is your late husband, Ukimi.
Do you know, Dr. Fundi, when she checked up on me after Kimi was buried and all that, she shared with me how it made her feel and all that. And when she said, I said to her, I wasn't crying a lot. And she said exactly what you're saying, that I should allow the tears to come, because it's a cleansing, it's a healing. Yeah. I'm a very practical person, and I don't cry often. I don't cry a lot. Hence, I can remember specific times when I cried. Like I can remember I cried when she spoke, and I haven't cried much during this 9 months. Yeah. But so I don't stop them. So this is why I'm crying now, because I felt now the need to cry.
Yes.
So, but thank you for encouraging me to cry, because people have got this thing of be strong and no, it's time has passed now. You shouldn't still be crying. So she actually used those words and just said, please let the tears flow. So it means that
And
the
I think,
doctors know what you're talking about. Yeah.
yes, and again, like I said, a grief process is unique to everybody. There is no one grief process efana with another one. And sometimes you take 3 steps forward towards, growing around that grief. And then sometimes something is a lemva, but that's part of the process. So, because again, you, as much as uthetha kakhulu, but certain things are private to you as well. You were able to keep it a secret to all of us. Yes, you were respecting his wishes, but she was like, but then when we knew that it's because it was Kimi's wish, as an invalid, then it makes sense to me.
It was not my story to tell.
Yes.
I just want to say thank you again to Dr. T for allowing me the space, because I immersed myself firmly and fully in their relationship. The relationship was between her and Ukimi, but he would go in there, as talkative as he was. I think every time he walked in there, it all played in his mind, I'm coming here for this reason.
Yeah.
She never said, okay, Mr. Mabutu, can you shut up now? I want to talk to my patient. She was really, really lenient and patient with me. And for that, I'll forever be grateful, because it got me to understand what was going on. It got me to be a better caregiver to Ukimi. So I'll say once again, thank you to her for that.
There's some people who are making some comments on social media, so I just want to then refer some of those comments to Dr. Keor. Nwanisa, okay. Can you read 1 or 2 of those comments, please, to Dr. Keor?
Okay, good afternoon, doctors. So we have
we can't hear you.
Can you hear me now, Doc?
Yeah.
Okay. So we have one comment on social media written by Debo Focus. He said, so true about trust issues, but I think the situation has improved over the years though. We only had that comment on social media and a comment from myself. So the question that I have for Dr. Keor is that are brain tumors very difficult to pick up? So the reason that I'm asking is because I know of a person who then passed on due to a brain tumor, but that was not picked up. She was then diagnosed of having depression because she was having a lot of headaches. But it was later on picked up, but during that time she passed on. So the actual question is this a cancer that's very difficult to detect?
Okay.
Yeah. I wouldn't say it's difficult to detect, but it again comes back to just a principle to say that any persistent symptom must be investigated. There are many causes for headaches. It could be stress, it could be, it could be fatigue, sleeplessness, etc. So of course we don't rush to scan everyone who comes in with a headache. It could be sinuses, but I always say that any persistent symptom needs to be looked at. So it's to say, okay, you've got a headache today. I think maybe it's depression, but let me see you in 4 weeks, or let me know in 4 weeks if you are better. So that if you're not better, we can look into it. So that sort of balances over investigation and reason. So that we don't over investigate people, but then we don't under investigate unresolved complaints.
Beautiful, beautiful, beautiful. So, Doc, you mentioned earlier the fact that during this time of COVID, you guys are seeing late presentations. Which obviously is going to create other problems. Was late presentations, it's stage 4, and therefore we now need you move to palliative type of care in a country that doesn't have enough capacity for palliative care. And generally, most of us, we like to look after our own person, at home, and all of that. So, what are your thoughts? What needs to be done in South Africa to try and get people to screen early? Maybe let's not even get there, to modify lifestyles those that are, to reduce certain risks, to early, detect, and obviously ensure early access to treatment. If you were an advisor to Dr. Joe Patla, who has just started as a Minister of Health, and maybe he wants cancer management in the country to actually be, improved, what would be the three things that you would say to him, to say, if you can do 1, 2, 3, it would turn, the trend of late presentations, and more of our people would survive cancers?
I would say two things. I would say education and lifestyle. And I mean that issue surrounding lifestyle, and that can happen from a young age in schools, in terms of activity, nutrition, because more and more we are learning about the impact of nutrition, and that's not really a discussion that is had in schools. I mean, even in medical training, if I look back at medical training, I don't really remember a lot of emphasis on nutrition, and that is why even as specialists, we often, don't go into the detail of nutrition, because we were trained to treat with medicines, but we really do need to refocus our minds on prevention. Yeah, otherwise no system in the world can absorb treatments. Honestly, even the first world countries, drugs are expensive, cancer care is exorbitant, that it is actually not sustainable. So to go and focus on, yes, we need to deal with that, but to go and focus on more treatments not going to solve the problem. It will just cost more money, and it's a bottomless pit, because the drugs cost an absolute fortune. Even in the private sector, oncology treatment is still largely unaffordable.
Yeah. Now, Doc, I like the fact that you are saying we need, as a country, to focus more on prevention, and lifestyle being one big part, but people will make lifestyle modification or changes because they have been given information that makes them to change their attitude, to change their behavior, their risky behaviors, so that their risk profile can actually reduce. So I'm very happy about that part. But then, there's one cancer where we can actually vaccinate and almost, eliminate, which is cancer of the cervix. Because, as you know, about 90% or so, I don't know if I'm right, HPV is the cause. Now we have the school vaccination program, HPV vaccines, but I don't think the take-up is that much, to make a dent, let alone in the private school, because it's only in public schools at this moment. And then you add the anti-vax community, which is giving us trouble with COVID-19 as we speak. One of our colleagues, it's reported this morning, one of our colleagues actually is rubbishing the vaccines. A colleague who's working in medical clinic somewhere in Cape Town, but so sorry, is it medical clinic? I think it's medical clinic. No, I think it's Netcare.
No, it's Chris Barnard.
Oh yeah, it's a Netcare hospital. Yeah, I'm sorry. I think it's Netcare. So when you have a situation where you've got this anti-vax community out there globally, that's intent on discouraging people to take things that are life-saving. So in the case of CA cervix, which is the #1 cancer amongst females, Black females in South Africa. So your thoughts around that, so let me throw that in.
So I think, so I don't have the details of the uptake of the HPV vaccine in schools, but my sense is that the anti-vax attitude really just became pronounced with COVID. Yeah. Prior to COVID, people didn't have a problem with vaccination. And for some reason, already was normal.
Locally, not so much, but globally, yes. Because the WHO put it in the top 3 risks to public health in 2020. You remember the outbreak of measles in Israel and also in the US last year and the year before, because parents are now choosing not to vaccinate their kids. But in South Africa, it really wasn't a big issue, but it is now seriously a big issue. And they're just looking at all vaccines, including vaccines like the ones that prevent CA cervix, that is the HPV vaccine.
Yeah, no, absolutely. And I think it brings us back really to education. And I must applaud government really for the rollout of the HPV vaccine in public schools, because, we will really see those results, in the next decades, when it comes to pass that the incidence of cervical cancer would reduce. So I think that it's about ramping that up, education, reassuring. And I think we can use the primary care clinics better to really facilitate sharing and disseminating of information at every opportunity.
Yes. All right. So, Doc, a certain percentage of your patients, because of late presentation and other situations, they unfortunately succumb to cancer. And you've developed relationships with them and their families, like we have just, spoken now with Usis Miranda. Now, how do you deal with that? Because remember now, they've become part of you for a number of months or years. How do you deal with that? Other people talk about vicarious what trauma and whatever, but as much as you are the treating doctor, but that loss also becomes loss to you, how do you deal with that?
The human heart and spirit have a tremendous capacity to healing. And so I acknowledge the grief.
Yes.
Right? And not wish it away. It's here. And I think that is what makes me who I am and who I am to the patients, right?
Yes.
But because we are given the gift of healing, I also similarly allow the healing to happen, and slowly you are able to carry on, because ultimately I also have to, the next patient needs me to be focused on them.
Yeah.
And like as Mrs. M said, the patient mustn't feel like they are in a queue.
Yeah.
They're seeing you, and so in order to do that, I have to get my spirituality, nurtured, and I have to also acknowledge the circle of life. The circle of life is that we are born and then we will die. And my feeling is that in as much as we spend so much time with antenatal classes getting moms ready for a birth, we should then similarly help people to have a dignified end. And so with that goal in mind, it helps in my mind to make sense of it, to acknowledge it as part of nature, that people will die. Mine happened to die from this disease, but people die every day from other causes. So yes, I'll grieve, acknowledge the loss, cry in some cases, but I need to almost resume and carry on for the other patients who still look to me to not fall apart.
Yes. Do you at any point do, regular debriefs, with a psychologist or something? Because it's an occupational risk for you, to get to a point where your cup gets depleted, the emotional resilience cup.
So I used to do that until it became one more thing to do on my list of to-dos, to drive to this person, sit there for an hour. So it was fine when it lasted, but I don't do that anymore because then it added pressure on my already long to-do list. So what I'm doing now is that I take 2 days a month off. So to make it a long weekend, like a Friday and a Monday, to not work, and rest and take the kids to school and fetch them and do those sort of everyday things and try not to look at my emails, because that's another discipline. You've got to have the discipline to not work. I always say to people, when you love what you do, you need discipline not to work.
Yeah.
to stop.
Yes.
So
Yes.
so I try and train myself to stop working.
But I know you've also taken up regular exercise
Yes.
as well.
Yes, and yeah, so I work out every evening, except for 2 days I rest. So that also helps. In that 30 minutes with my headphones, there's no one else but me, and that also helps for me to sort of calm down. I try to do mindfulness, but my mind can't stay still for that long. Then I start thinking, so I just too much, I can't do it. So then I exercise. At least then I can still think while I'm working out. I can still, my mind can still be active. So there's nothing wrong with mindfulness. It's probably very good, but my mind, I can't be quiet for that long.
All right. And so you told us about the mentor that brought you to Sentin Oncology. And, it was a male who opened up an opportunity for you.
Yes.
So at least this gender is not so bad,
Not always lost,
Yeah,
but
but
the
anyway,
male didn't have melanin, huh? The male didn't have melanin.
Exactly. Yet she actually, created opportunity for you. And look at where you are now. Not that you were not going to get to where you are, but it did make a bit of a difference to have somebody who's already walked the path before you, who's actually just holding your hand so that you can avoid certain pitfalls. But now you are also paying it forward by doing stuff for young girls. Tell us a little bit about that.
So, I think that in the lifespan of a person, in your early sort of 20s, 30s, early 40s, it's about achievement. You want to achieve stuff. And then you get to a point where then you have achieved in the definition of the world of achieve. Yeah. But then you start to want to do legacy stuff. You want to do things that one don't necessarily pay you. Yeah. But that fill in a gap. Because there is a gap that's no amount of perceived success. Perceived, because success means different things to different people. No amount of perceived success can fill. And I think that happens in your mid-40s, where you start to look around you. Now it's no longer about the success, and that it's about, okay, what am I contributing?
The reason why you are here on earth.
Yes, what am I contributing? How can I make a difference? Cliche as it sounds, but I think in your mid-40s you start to realize that you gotta do something before you leave.
Yes.
So then I felt that we discussed and we thought this is how we could impact girls, because in fact the whole Happy Me pad, pad is just the vehicle to connect with the girls. Yes, it speaks to a need of period poverty and so forth. But actually, for us, it's multi-layered. Beyond the pad and what that does for their confidence, there's another layer of connection with the girls, inspiring them without saying that I want to inspire you, but saying let's connect, let's discuss, let's talk about things you can't ask at home. Here I'm bringing you a friend of the foundation who's a gynecologist, who's gonna talk to you, who looks like you. And subconsciously, I'm hoping that it will say, listen, look at these people, look at this girl, grew up in a village, went to school in another village, talks like me, can speak my language, look at her. I'm hoping subconsciously, without it being a someone, it will click that it means that I could also have a license to dream.
Beautiful.
Actually, that's what it's about.
Yes. So, Doc, what's next for you? Obviously you started entertaining the issues of legacy. Or what legacy do you want to leave? When you decide to hang your stethoscope now and say, no, I am done. I now want to enjoy myself and my spouse and my kids. Maybe it's emptiness syndrome at that time,
So lately, and I won't say too much about it because often people say don't announce, just do it. But so I won't give the detail. But I'm feeling an agitation to go back into academia. I want to train a new generation of oncologists. Beautiful. And I'm feeling that unsettledness now. So yeah, that's all I'm going to say. That's where I'm thinking, and yeah, watch this space.
Beautiful, beautiful, beautiful. So no, I'm happy. I'm happy because I think there must always be something that you look forward to doing to stretch you out of the comfort zone of what you've become comfortable with. You know, I'm seeing a lot of trend of clinicians who are now getting involved, you know, in research. You know, yes, you are as part of the global network of oncologists, but you know, so this breed called clinician scientists, you know, where there's you almost like a schizophrenic. On one side you're a clinician and you take things from this side and you're involved in research and you are teaching as well. So basically it seems that's the direction that you are taking, and yeah, and it's gonna multiply and make more kiosks out there, and that to me can only be benefit to South Africa and the world. All right, so what's the last message you have to women of South Africa, being August, a month of women, as we are about to wrap up?
I would say, you know, that, and I think this may have been repeated and repeated, but I do think we need to remember that we are enough. You know, we work and improve ourselves and we must keep moving, but ultimately we are enough and it's okay. You know, in whatever sphere that we find ourselves, in business, in medicine, we do have this voice, and I imagine that we a lot of people have it, including men, the voice that wants to suggest that you aren't, that you are, and you don't belong here, that you are not good enough, that soon someone's going to discover that you actually don't know what you're doing. We need to work that voice out of our system, you know, because I think that has the potential to really slow us down.
Yeah. So self-belief, self-confidence, understanding why we are here, and that the gifts and the talents and the opportunities before us are there not for ourselves, but to make the life better for humanity. You know, that's what I'm hearing you say. Sis Miranda, amazokugqibela kugqirha omkhulu. Sis Miranda, please unmute. Just your last words to our special guest.
I thought I said everything.
No, I know, but I also know that when you've got, you know, the words, you've got a lot of words. Allocation yakho per day is more than most of us.
No, I don't have much more to say except to just reiterate my gratitude to her and to you for this platform, and she must continue being the shining light in the world, and we are blessed that she was given this I don't know what to call it, a skill, but the fact that it can help so many people, because it doesn't only end with her and the therapy. She gives so much more, and now I can look back and look at a journey that was not nice, but was made bearable by her being by my side. And as I say again, I would wish anybody with cancer had Dr. T in their lives. But I'm praying that we don't get many more new diagnoses, because it's not a nice journey. It's not something nice to go through. And and not just her, staff side in some check up on me, and they SMS me and ask me how am I doing, and they still talk about leukemia. And for a person that has lost a loved one, that's huge, because it says this person lived and people remember and he made an impact. I mean, they don't have to do that because they don't owe me anything. The patient was leukemia, but they still check up on me and say, Mama Kwetu, how are you doing? And when I say Dr. T, I mean Dr. T and staff Sake Sonke, from the cleaning lady who kept the place clean and smiled at us, the receptionist, the one who scheduled, the nurses. They're just it's just a very, very warm group of people. And I know that they deal with people that are worried about issue at some stage, but they don't look at you and look at you with pity. They look at you and give you hope.
Yeah. Okay.
So I am grateful again, and
Yes.
thank you, Nakube.
Okay. Enkosi kakhulu ke sisi wami. Enkosi kakhulu. Thank you very much. Doc, I think we can talk until tomorrow, but at least, you know, you were talking about, you know, the legacy and stuff. And now this is what I do, not for, you know, any payment. I just feel that there is no platform out there to ensure that health matters, you know, are actually, you know, discussed. They are normally just done as a small this and that on mainstream media, but even more important to acknowledge, you know, the professionals of South Africa. Obviously, it's a healthcare channel, so there's a bias towards healthcare professionals to say to those who are doing great things, keep going, keep going. South Africa needs more of you. And so to you as well, I'm just saying thank you for being a pathfinder, a trailblazer, a pioneer. So many have followed. I think we've got just over 20 people who are now medical oncologists since you started 13 years ago. And some of them were definitely inspired by your success. So just go there and now be actively involved in producing more. So if I use the language of Winnie Mandela, where they say she multiplied, so go and make sure that you multiply. And thank you very much for giving us your Saturday afternoon, because this is family time. You could have chosen to say, I won't be able to do this, and I would have had to understand, but you were gracious enough, in spite of your busy schedule, to actually agree to this. So thank you very much, and thank you to everybody who joined us, you know, and I hope that by listening to this conversation with Dr. Keor, you've been able to be inspired. And if your child wants to be a medical oncologist one day, then you know the person that you can arrange with for that 1 hour shadowing. I'm sure she would graciously agree if you request her on time. So thank you very much, Doc.
Thank you so much for having me. And also thank you to Mrs. Makwetu, just for allowing me to journey with you and Mr. Makwetu. You know, that for me as well was an honor to journey with you both in this time.
Thank you very much, Kate. All right, thank you, Nwamisa, for supporting us. And tomorrow we will be back. We will be profiling another young medical professional, you know, Dr. Uitumelo Pagati, who is a general surgeon and the head of breast and endocrine unit at Charlotte Maxeke Academic Hospital. So till tomorrow at 4 o'clock. Thank you very much.
Thank you.
Thank you.